Alvarado. El doctor Alvarado es profesor de cirugía en la Universidad de California, San Francisco, es de la División de Cirugía General y director del Fellowship de Cirugía de Mama Oncológica. Doctor Alvarado.
Thank you very much. Good morning. Buenos días a todos. Thank you so much for the invitation to come here. It's always wonderful to see all these wonderful people, and I've gotten to have such wonderful friends here in South America. And I really appreciate you having me get up this early in the morning to give this first talk. I'm going to talk today about the changes in the staging system for breast cancer. A lot of it is pretty reasonable. I think you will understand why the changes, especially from your own experiences in clinic. And we'll go ahead and get started with that. These are my disclosures. So the changes in the staging criteria for breast cancer, and really now looking at prognostic stage compared to the classic anatomical stage. So not just the tumor size, the nodal status, but now looking at prognostic characteristics to have the discussion of what we call stage. And we'll review these updates and how they're used. So what is the classification for staging? Why do we have the classification for staging? Well, it's supposed to help have a discussion or a common language among physicians and patients to understand what their prognosis is. It's also supposed to help us gather information so we can look back and identify what's happening to these patients in specific groups. Develop guidelines to develop treatment factors for patients based on stage, tumor size, nodal status, and help us give very good clinical care. And the staging system has changed over a number of years, and you can see here that's gone through different iterations or changes from the very beginning and expanding now into what we would call prognostic staging as well. Now, the old staging manual was a very nice small book, and if you've seen the new one, it's rather large and very, very deep with a lot of information, and you can see the difference with regards to the number of chapters, the number of pages, and the overall size of this book now. So classically, staging was based on tumor size, nodal status, and whether or not there was metastasis. And the staging table was rather easy to look at, easy to figure out where your patient was to give them the information about stage, help the oncologist look at stage, pathologist, and the rest of us. But now, we're really looking into what's called prognostic stage. So adding prognosis into the classic tumor size and nodal status to give a better idea of what's going to happen to that patient and to determine what the best treatments are based on this information, and not just the tumor size and the nodal status. And we all experience this in our own clinics, right? The patients frequently say, well, what do I have? What does the biopsy show? How serious is this diagnosis? Am I going to die from this cancer? What are my treatment options? And what do we do next? And pretty much every single time, even before we operate, before we do any studies, the big question is, what is my stage? And unfortunately, today with computers and the internet, patients then go onto the computer and start looking up stage, and before you know it, they're coming back with all sorts of questions, whether they may be important or not. So just to give you an example, you can see here two patients. One woman is 42 years old with a 1 centimeter tumor, lymph node negative, but she's estrogen, progesterone, and HER2 negative and grade 3. The second patient also has a 1 centimeter tumor, lymph node negative, but she is estrogen positive, progesterone positive, HER2 negative, and grade 1. By the old staging criteria, they both have a stage 1A breast cancer. But I think it's pretty obvious that they have very different prognoses, or potentially different prognoses. And so this is the issue that the staging system is now working on. And there was a lot of data that had been already published before the changes, specifically here from the MD Anderson, looking at almost 4,000 patients, and how adding in prognostic characteristics like estrogen, progesterone, and grade changed significantly how they regrouped patients. And then an extremely large database from the National Cancer Database of 300,000 patients looking at survival based on these prognostic characteristics. And it was noticed that it's much better to add in estrogen, progesterone, grade with the standard staging system to get a better idea of what's going to happen to these patients. And you can see from moving from the old criteria to the new criteria, there's a large percentage of patients, about a third of patients are moved from a different staging group with these new prognostic characteristics. So it does make a big difference when you add in these prognostic characteristics. And these are just some graphs to show, which I'm sure it's pretty obvious, but from these 10-year breast cancer specific survival curves, the difference between just estrogen negative and estrogen positive breast cancer patients. So that makes a huge difference on prognosis and should be incorporated. And you can see here when you start looking at stage, kind of classic staging system with tumor size and nodal status, and you look at triple negative breast cancer versus estrogen positive breast cancer, there are very significant differences in breast cancer specific survival. And here it gets even more complex, as you can imagine, when you start adding in grade, estrogen, estrogen negative, tumor size, nodal status, and you start seeing that you can regroup patients. A woman with a very small triple negative breast cancer may have similar prognosis to a woman with a larger grade 2 estrogen positive breast cancer. So you start getting these groups of patients based on outcomes, but they look very different with regards to biology and classic anatomical stage. And when you do that, you can start grouping these patients into risk profiles. So you can see here you have risk profiles such as 0, 1, 2, and 3, and you can have these risk profiles in different classic anatomical staging systems. So within stage 2B, you can see the risk profile of 0 has almost 100% 5-year overall survival, even though that patient is stage 2B, which is very different than, for example, a woman with stage 2A that has a risk profile of 3. So you start seeing how you can regroup patients based on these risk profiles and get a better idea of what their prognostic categories are. So not just the prognostic staging system, but there has been some other changes also in the tumor categorizations, the tumor categories. So lobular carcinoma in situ is removed from the T in situ category because it is more of a risk factor as opposed to an actual in situ cancer. Rounding tumor size now, but not rounding down to microinvasive. For multiple tumors in the breast, you use the largest dimension of the largest tumor and not the overall size of the multicentricity, but they must be macroscopically identified. And then also looking at the concept of satellite tumor nodules in the T4B category. Also for the lymph nodes, when we start doing the grading system here, or the staging system, for clinical node evaluation, the clinical node 0, when the evaluation is possible, physical exam or imaging is negative for nodal involvement. That would be clinical node negative, node 0. NX would be if the nodal basin was previously removed. And then now for the microscopic measurement of these lymph nodes, you're looking at the largest contiguous tumor deposit for the pathologic nodal stage. So if you have this small areas within the one lymph node. You don't measure the entire size, but the largest area of that microscopic finding, especially if there are multiple tumor deposits in that lymph node. And then here you can see that the changes also with metastasis for clinical metastasis as well as pathologic. In the post-neoadjuvant, so after neoadjuvant classification, using the YPT categories, again, looking at the largest focus of residual tumor for YPT, treatment-related fibrosis near the invasive tumor is not used. So if you have response, so you have fibrosis in the response, that is not counted in the residual tumor burden. It's only the actual tumor cells that are there. But the neoadjuvant classification will continue to be undergoing changes. I think now that we're identifying that prognosis is also dependent on response to therapy. So at this time, it's not built into the staging system or the prognosis category, but I think you'll see a number of changes in the near future with regards to following neoadjuvant therapy, now based on response to therapy, because as you all know, there's a lot of data showing that, for example, complete pathologic response showing a much better prognostic category than a non-complete pathologic response. And also moving from standard measurement of the residual tumor in terms of just size, and now looking at something, for example, residual burden in terms of RBC, and looking at, or RCB, excuse me, residual cancer burden as a way to define prognosis as well. So there will be some significant changes in the neoadjuvant groups as we go forward as well. The multi-gene panels now have been added to the staging criteria. The Oncotype assay was the original one that was placed with level 1 evidence, but also in that staging system. Now you see the other multi-gene panels with level 2 evidence being able to be used for prognosis as well. Again, this original data in the AJCC was based on the first data coming from TAILOR-X for those patients that had low recurrence scores, less than 11, showing their very, very good prognostic outcomes with hormone therapy alone. And because of that data, this was incorporated into the AJCC manual. And that, I think you'll all realize that in the future, they'll start adding more and more with regards to these molecular assays, such as the 70-gene assay, for example, as more data comes out, putting patients in better prognostic categories based on molecular assays. So here you can see, even with a T1 or T2 tumor, with the HER2 being negative, any grade now, so grade 1, 2, or 3, any PR or progesterone status, as long as they're estrogen receptor positive, if their recurrence score is less than 11, they automatically become stage 1A. So a really good prognosis for patients, irregardless of their tumor size and their progesterone status. However, when you start incorporating all of this, it does start to become extremely complicated for looking at these patients' staging system. And as you all know, in our hospitals, and probably here as well as in the United States, we have people that are recording the stage for the cancer databases, and this becomes very cumbersome to identify what the actual stage is for the patient. So you can see here, this is just one snapshot of T1, T2 patients looking at the expanded anatomical factors and the ER, PR, and the differences between staging system 7 and staging system 8. And then here you can see it becomes even more complicated for the pathologic prognostic groups when you start factoring in that as well. But you can see just from a T2 N1 tumor or a T3 N0 tumor, depending on HER2 status, depending on ER and PR, you can get a lot of variability just for these two classifications. And again, just pointing out that a patient that was previously a stage 1B or a stage 2A, you can see here with the recurrence score less than 11, these two women automatically become stage 1A. So utilizing this information really can help with our patients in the clinic to help them realize what their prognostic stage is and give them a better idea on an individualized basis as opposed to these large cohorts of women. Because previously, we would sit with our patients and say, yes, I know that you have a tumor that's 4 centimeters in size, but it's a grade 1, strongly ER/PR positive, node negative. You're probably going to do very, very well based on this data, as opposed to a woman that had, for example, a triple negative breast cancer. But as I was saying, it does become extremely difficult. Previously, for staging, for myself, it would be pretty easy. I just go on the computer, look up the stage. There was one small table, and I could always easily find it. Now it's becoming much more difficult, I think, as illustrated in this very highly technological discussion here between these two professors and the mathematics. It does seem like it's a little bit crazy when you start thinking about moving from the anatomical stage to the prognostic stage. I have not used them, but there are these applications for smartphones that you can use. I'm not sure how well they work, but there are a number of apps you have on the iPhone and other smartphones to be able to better identify what the prognostic stage, and really now thinking about what the vision is for the AJCC, moving from, as you remember, it was just the TMN staging just based on pathologic anatomical size, but now moving into the prognostic factors, so adding in estrogen, progesterone, grade, and now molecular assays to get the best prognostic information. We can start regrouping our patients, and that not only helps with patient satisfaction and individualized treatments, but now we should start thinking about better ways to go back and look at patients. So instead of just going back and looking at all stage 2 patients, now we can go back and look at stage 2 patients that were actually prognostically categorized in the right way. And now the AJCC wants to use this for precision medicine and really look at risk assessment tools based on these prognostic characteristics, factoring in the future genetic assays and gene assays for patients, and then looking at ways to better put patients in clinical trials, right? Because, for example, just if you just think about neoadjuvant trials and say, well, we're going to have a neoadjuvant trial to test this new chemotherapy for patients that have node-positive breast cancer. Well, if you start adding estrogen-positive breast cancers that are grade 1 with triple-negative breast cancers that are grade 3, you really get a big mix, and you're not going to get the response to that chemotherapy that you would expect for the high-risk patients. So being able to utilize these types of information to better stratify patients for clinical trials will give us better information for these newer treatments so that we can move forward in this way as well. So although it is more complicated and it becomes difficult to find the exact stage, I think in the future it's going to be much better for our patients and for the way we treat patients and the way we start utilizing it in clinical trials as well. And with that, I again thank you very, very much for the opportunity.
A continuación, invito a la doctora Elenice Gobi. Ella va a hablarnos sobre la inmunohistoquímica versus los perfiles genéticos.